Hi everyone, my name is Brooke Rossi and I am a reproductive endocrinologist and infertility specialist at Ohio Reproductive Medicine. And I'm so excited you decided to join me tonight. It is, at least in Ohio, a beautiful summer night and you guys could all be probably hanging out by a pool or walking a dog, but instead you decided to join us here tonight. So thank you so much. Um, I just, I don't know. We ahead of time we had some patients ask us questions about the ruling from the Supreme Court on Friday, and that might just be a kind of a good place to start because we've gotten a lot of calls in the last few days from current patients, from past patients. We have patients coming into the office asking us questions. And I just want to make it very, very clear that as of right now in Ohio, all of infertility treatment is being practiced as it always was. There are no new laws today or a few days ago that change how we are doing our infertility treatment. There are no laws right now that change how we are doing IVF. There are no laws right now that are changing how we're dealing with our embryos, whether they be fresh embryos or frozen embryos. But I will say this is concerning to most infertility doctors around the country, actually. And not sure if you guys are aware, but all the doctors at Ohio Reproductive Medicine, and probably most of the doctors in the state, if not the country, work under an organization called the American Society for Reproductive Medicine. And they're called the ASRM. And we have been working with them. They have been really trying to help all doctors around the country understand sort of the implications of these new laws. Again, the other law that changed in Ohio recently was that there's now a 6-week abortion law, which again doesn't affect how we treat our patients at this point, but we take care of patients who have devastating things happen to their pregnancies, and so we care about all those patients as well. So some of the reassuring things that I want to say to everybody right now is that again, this does not affect how we deal with anybody's embryos. I don't think that anyone needs to send their embryos to another place. Okay, so all the embryos are safe. You don't need to do anything with them, any of that. I also don't think that anybody needs to worry about what would happen to them if they had a miscarriage or what would happen to them if they had an ectopic pregnancy. There's no laws in Ohio right now that are dictating that we have to do anything but different care for our patients who have ectopic pregnancies or miscarriages. So I want to reassure patients of that. However, I think that we are all a little bit nervous about if there's any implications on the future for our patients in Ohio and potentially all around the country, but obviously we were worried mostly about our patients in Ohio because that's where we practice. And it is true that our ability to practice IVF in the appropriate evidence-based efficient way that we have been practicing it for decades could be at risk and could be targeted by some of the laws that have been discussed around the country. This, at the heart, kind of gets down to how pregnancies are defined and, quite frankly, like when people decide if life begins at fertilization or not. And so we are really trying to make sure that the legislature and the laws makers of Ohio understand that that if the laws are written in such a way that they talk about fertilization, or the laws are written in such a way that they specifically have implications on IVF or dictate how we do IVF, that will affect our patients. And we do try to remind them that, as you all know, we are here to help build families and to take care of women, and we take care of women in every way that we can. And I do think that even some of these people who are making these laws actually are pro-family just like we are. But I don't think they quite understand the implications of some of the words that they are saying. So one of our people that works on our website, our marketing team, Alex, helps me do this every time we do this. And I'm going to see if Alex, maybe in our comment box, can put in 2 different websites for 2 different organizations. One would be for the ASRM, so the American Society for Reproductive Medicine, and that's asrm.org. And the other thing that I would like her to also add is the website for Resolve. So resolve.org may be an organization that some of you know about. If not, you should probably check them out because they're a very good infertility awareness advocacy organization. They also have a local support group and a lot of resources on their website as well. And I think that if you look at these websites, the ASRM and resolve.org, if you are feeling like you want to do something to help make sure that the lawmakers in Ohio understand that infertility treatment is important, that care for women is important, you know, they don't listen to me all the time. But if patients and your friends and your family all start to remind them, hey, you know, in Ohio, we need to take care of our women patients and we want to build families. And if our ability to practice fertility treatment in an effective way by limiting IVF is at risk, that will impact our ability to provide infertility treatment in Ohio. So anyways, there it is. Everything is fine for now. So I want everybody to just be okay and take a breath. You know, I went to this, the ASRM had a kind of like a doctor's meeting the other day, and they had a panel, and there was like the doctors, and there was a lawyer, and there was actually on the panel there was a psychologist, and she was talking a lot about how people were feeling, and she was talking a lot about how we need to support each other and take a minute. And I thought, wow, I'm so happy the psychologist is on this panel because it's been a really hard and kind of scary few days. But as we always have when taking care of women, we just wake up every day and we take care of our patients the best that we can, and we will continue to do that. And so I just want to reassure everybody that that we're going to keep working. Everyone's okay. No one needs to do anything different, and we will also update you as soon as we know anything. I just want to say one more thing. We actually are in contact with all the infertility doctors in Ohio. We're trying to share information. We're trying to work together. And so as soon as we know something, if we think that we need to change the way we're practicing, if we think that we need to do something different with people's embryos, and we will definitely let you know as soon as we can. I don't know if you guys notice, I have to read and talk at the same time. So sometimes I look to the side and I stop talking because I just want to make sure I'm not ignoring anything. While we're on this subject, it looks like some patients have just some questions about, again, just about miscarriage. I really can't imagine how having a miscarriage would in any way be affected by any other ruling. Well, let me say this again. It's a possibility that some of the medications that we use to help patients who have missed miscarriages, which means that maybe the pregnancy has stopped growing, but the woman hasn't passed the pregnancy yet. So as some of you may know, there's a medication called misoprostol that we use for that. It is possible that maybe we have to let the pharmacies know with a little bit more clear definition why we're using that medication. But that medication is been around for many, many years. It is used for a lot of different things in gynecology and either in other specialties. So I really don't think that women who have had true pregnancy losses are at risk, or ectopic pregnancies. I really don't think that that they are at risk for having their management of their pregnancy loss. I don't think they're at risk for having that change at all. Okay. Let me see if there's And again, for some patients who have had ectopic pregnancies, I think that would also have appropriate care. There's, as some of you may know, there's another medicine called methotrexate that is used for ectopic pregnancies. I have not heard or seen that is at risk at all either. So, anyways, if anyone has any more specific questions about that, I can always go back to this topic. This is obviously something that we're talking about all day long. Our patients are asking us about all day long. So I just wanted to reassure you guys about that. One of the things that I had a couple other questions that came up in the last few days, and please add some questions to the comments here. That would be great. Anyways, we had some questions about kind of prepping and maybe preparing eggs, and I would say even eggs and sperm for IVF. This is always a really good question, and I do think that to have a healthy embryo to some degree, part of that deals with the quality of the sperm and the quality of the eggs. And the eggs and the sperm actually take about 3 months to be made. So, for example, if there was an intervention, let's say maybe somebody was a smoker and they stopped smoking or they, stopped using a medication, it will take several months for that to wear off and the implication of the egg and the sperm. So I think it is important that patients try to be as healthy as they can before they do IVF to potentially help their embryo quality. Now, there is not clear data on different supplements or lifestyle or any of that stuff, unfortunately. I think what I would probably say in general is some of the most clear recommendations just say things like try to make sure that a woman's taking a prenatal vitamin with at least 800 micrograms of folic acid. She should try to make sure that she's taking appropriate amounts of vitamin D and maybe an extra not an extra prenatal, but like a prenatal as opposed to just maybe a multivitamin. And I also think too, we do see differences with IVF in body mass index, so trying to make sure that people are as close as they can to their goal weight if that's an issue. And I think the same is true for the sperm as well, which is that the sperm are just as important as the eggs are. We want to make sure that our male partners are healthy, that they are not smoking, that they are, have limited alcohol use, and that they're watching sort of like maybe other chemicals that they're exposed to potentially at their job as well. Let me see here. Let's just see here. Hold on a second. And I just want to look up at this here. I'm just going to go back to just real quickly about the extra embryos. If patients have extra embryos that are frozen, or potentially even extra embryos that are not frozen with IVF, that's a great question. Right now, everything is the same and we're not changing our practice. But this is an example of really making sure that our legislature understands that, that a fertilized egg needs to still be, that is up to the patient to decide how they choose to deal with that embryo. And so that is a perfect example of what we need to let our lawmakers know, that IVF patients should have control of what happens to their embryos. Right now, everything's the same, but I do think that is one of the things we worry about, that there will be laws dictating what we can and can't do with embryos and what our patients can and can't do with their remaining embryos. So there is a patient, let me see here, there's a patient, looks like it's maybe asking a question about maybe tubal factor infertility. So this is actually interesting, because if for any of you who maybe have met our team in the office, we ask a lot of questions. We ask a lot of questions when people first come in, because we feel like feel like an investigator to try to understand what's going on. So one of the things we always ask about is if, the surgeries that people have had, because we're trying to understand if there's any chance that someone has had a pelvic surgery that could affect their potentially like structures in the pelvis, like the fallopian tube. So one of the things actually that can happen, and I have seen this, if a patient has a history of a ruptured appendix, so not so much like, oh, I had appendicitis, I went to the emergency room, they took out my appendix, it went fine, I went home the next day. But I'm talking about patients who have had, an appendix that ruptured. I even saw someone who had their appendix rupture when they were probably 2 or 3 and had scarring. So the appendix is on the right side, actually pretty close to the fallopian tube in the ovary. And sometimes if patients have an appendix that ruptures, they can have scarring around that area. And it can be significant scarring such that the fallopian tube can be affected and blocked. And so I don't know if you can see this in this question that one of the participants asked, but she said, my fallopian tube was blocked on that side from my infection, and my doctor thought that that was related to my infertility, so I had it removed, and it sounds like the patient still has not gotten pregnant. And it is possible that having that fallopian tube removed will help fertility. There is something called a hydrosalpinx, and a hydrosalpinx is when there is fluid in the fallopian tube that collects. And if you think about it, the fallopian tube is attached to the uterus, right? So if there's a lot of fluid in the fallopian tube, sometimes it can back up into the uterus, and it makes it hard for an embryo to implant there. And there's always been a concern about this with in vitro fertilization, that if someone has a blocked fallopian tube or a hydrosalpinx, that it may impact their chances with IVF. So sometimes we will remove a hydrosalpinx or a blocked fallopian tube before IVF. It's not really clear what that means for patients who have an open fallopian tube on the other side or are trying on their own. The data are not quite as clear. And so I think the patient was concerned about if there could be any other fertility issue going on. And, if we really think that the tube has been removed, the other tube is healthy, it's almost kind of like that person looks like they may have unexplained infertility then. So they may want to be treated with the treatments that we use for unexplained infertility, which may be medications and insemination, or may even be in vitro fertilization as well. We have a patient who is asking about age and IVF, or age and infertility, and that's a great topic. So in terms of age and fertility, there is something called age-related fertility decline. And what that means is we're born with all the eggs we're ever going to have, and we carry them around with us everywhere we go, and they're exposed to everything that we're exposed to throughout our lives. And then as we get older, so when I say older, I'm saying, mid to late 30s into the 40s, etc. When our eggs meet the sperm, and the chromosomes are supposed to rearrange and mix, right? Well, as the eggs get older, they don't do that part as well anymore. And so what ends up happening is, the sperm and the egg meet, the chromosomes don't rearrange properly, and then what happens is those offspring or those embryos don't have the right number of chromosomes. And so that can result in either infertility, like a difficult time getting pregnant because that pregnancy is not genetically normal, or sometimes can result in miscarriage. And so with a decrease in fertility and increased risk of miscarriage, what that means is overall your chance of having a baby is lower as women get older. And that happens to everybody. The age-related fertility decline probably starts to affect, I would say, the average woman probably around 34, 35. Now, it does not mean there is no cliff that everybody falls off of when they turn 35. I didn't pick the advanced maternal age as 35. I don't know why they picked 35. Well, they probably saw some decrease. But my point is that some women are worried that as soon as they get to 35, all of a sudden they have all these extra risks that they never had before. And that's not totally true. You may have an increase in some risks, but it goes down slowly first in the mid-30s, and then the late 30s a little bit quicker, and then after 40 it can go down quite a bit. And so we definitely see this impact of age-related fertility decline when we look at IVF outcomes. And we can see that probably the biggest determinant factor of success with IVF is the age of the woman who's giving the egg. And so we see that, at 33 or 32, if everything is equal, the chance of getting pregnant with IVF and having a baby might be 60%, and at 41, it might be 30% or something like that. And that is just because of the risk that the egg is not going to give us a genetically normal pregnancy, which then would continue. And so, we can't change our ages. That is one of the reasons why patients may decide to proceed to IVF maybe sooner, but that's not always the case. I mean, sometimes what we see is that IVF can't overcome the impact of age, and we'll talk to people and their chance with IVF might be as good as with IUI, and so sometimes we do insemination instead. So, but age of the woman is probably most significant in determining IVF outcomes and success, and true overall with fertility as well. Someone is asking about recurrent pregnancy loss, and so this is a good question. I'm laughing because I am probably guilty of giving a lot of progesterone to my patients with recurrent pregnancy loss. So it is, one of the, because we see patients with infertility, and obviously we take care of patients with recurrent pregnancy loss as well. And they are both very, very difficult diagnoses, I think, for patients to have. And sometimes, unfortunately, patients even have both of those problems. And when we see a patient with recurrent pregnancy loss, there is a kind of like a recommended list of things that we look at that are evidence-based, that we have good tests for, that we know are related to pregnancy losses. And that can be hormonal issues like uncontrolled diabetes or thyroid disease. It can be an abnormal shape to the uterus, like a uterine septum. It can also be something called antiphospholipid syndrome, which is an autoimmune blood clotting disorder. We also will sometimes look for something called a balanced translocation, which is an abnormality in the sperm or the egg, which predisposes the couple to have a high number of abnormal pregnancies. And that is about where the list ends as terms of the evidence-based things that we do. And that, we'll do that testing on people, and probably still about 50% of patients aren't given an answer for why they're having pregnancy losses. So then there's like other things that we start to look for. And one of the things that people have been looking at over the years is looking at the fact that maybe there is an issue with any particular woman's progesterone production, or an issue maybe with what we call her luteal phase. So the luteal phase is the time in the cycle between when somebody ovulates and when they have their next period. For most women, it's somewhere between 11 to 14 days. And during that time, the corpus luteum of the ovary starts to make progesterone. It also makes estrogen. And that is when implantation happens. And so there are some people who have thought over time, well, if a woman has a luteal phase defect, which means that maybe her body's not making enough progesterone, that wouldn't be enough then for implantation to occur and for the pregnancy to be established. And that's a pretty controversial topic. Like, it's not clear how we diagnose that. It's not clear how we treat it. The data really aren't clear about it. People have done different things about it over the years. But there are some people who would say, well, if you think somebody has a luteal phase defect, or they're having miscarriages and everything else is negative, then they should start progesterone just in case. And there was a really good study that came out in one of the biggest medical journals in the country called the New England Journal. And that came out probably, I don't know, maybe 5 or 6 years ago now. And it was a really good study. And they looked at a bunch of women who were given with no reason or no known reason for pregnancy losses. And as soon as the women got pregnant, they started them on progesterone. And then they looked at women who didn't start progesterone, and the chance of having a baby was the same in the same group, in both groups. And so authors of that paper kind of said, look, like there isn't really clear evidence that giving a woman with recurrent pregnancy loss who doesn't have a known cause for it, there's no indication to give her progesterone. It's not clear that it helps. And so, you know, sometimes depending on sort of the clinical situation with the woman, what the cause of her loss was, sometimes patients are offered progesterone. Sometimes they're offered progesterone even before they get pregnant, like they're given it in the luteal phase before they find out if they're pregnant to try to help with implantation. But it's not totally clear that that is the right thing to do. I mean, I think if you were going to do it, you might want to start it earlier as opposed to waiting until until you find out that you're pregnant. But again, that data is like really kind of shaky, and some doctors do it and some doctors don't. And I can see why, because the data aren't totally clear. So we do know that progesterone is important. Obviously, anyone who's done IVF understands, that we are really careful about giving people progesterone and that they need it. It's a little bit different in our recurrent pregnancy loss population. So, all right. I'm just looking here. So many exciting things, you guys, you want to know about. What was the one thing I wanted to see? I think that this one will be kind of maybe a little on the quicker side. One of the patients asked about, oh gosh, you guys, I'm sorry, my dog's in the room. I think he might bark. I'm sorry if the dog barks. Anyways, oh, now he's going outside. Anyways, when we do these telemedicine visits, I get to see everyone's dogs and cats now, and it's always really fun when we see them. But okay, so one of the participants had a question about using metformin for PCOS, and specifically asked about metformin and Clomid. But what I will say is that there, in the last probably maybe 10 or 12 years, it's become quite clear from really good big studies that that PCOS is best managed if a patient can tolerate it. Probably best managed by letrozole over Clomid. Chance of having a baby is better, especially in patients who have a body mass index more than 30, with letrozole compared to Clomid. And that the role of metformin is not quite as clear. So they did a big study where they looked at giving people Clomid, just giving people metformin, and then giving them both, and there was really no benefit to giving people metformin and Clomid together. So how we give metformin kind of varies from person, maybe provider to provider. It's not really clear that it should be used in everybody, especially if somebody does not have prediabetes. So it may kind of depend. I use it sometimes in patients who maybe are what we call resistant to letrozole or Clomid or both, meaning that I've tried just those medicines by themselves and people are not ovulating. It may be that those patients need a little bit of help with their insulin resistance, which is what metformin may help. So that's kind of a little trick we do sometimes to try to help the oral medications work in patients with PCOS. Okay, there was another question. I wanted to address this because I think this is interesting, and I'm always, I get a lot of questions about when so kind of like your egg reserve and what happens when you do IVF, like if you're using them up faster. This patient was specifically asking about kind of like PCOS and the process of age fertility decline. So again, hopefully not too many of you have heard this analogy that I try to tell people. So here's how I think about the ovaries. Every month, the ovaries, so if you guys have ever heard of an antral follicle count, sometimes people have heard of that or they've had them done. So imagine that you have your ovaries and there's a track, they come up to the starting line, okay? And you look at how many eggs are at the starting line. That's the antral follicle count. It's how many eggs are getting ready for that particular cycle. Okay, so let's say you got 10 runners or 10 antral follicles. In a natural cycle, what will happen is, the hormones start being released from the pituitary and all the little follicles start running. But one of them is going to get the receptors, and that's the one that's going to take off, and that's the one that's going to ovulate. So in a natural cycle, that's, most people only ovulate one egg. Well, those other 9 little runners or 9 little antral follicles, then they die, okay? When you do IVF, same thing. Let's say you get 10 that come up to the starting line, and because of the different IVF medications that we use, they all start running, but then they all can continue to run the race. They all continue to run the race, and then 10 of them finish. That's how antral follicle counts are kind of related to how many eggs you get with IVF also. So whether you're doing IVF or not, or IUI or not, like if you didn't use those other 9 eggs, they're just gonna die. So it's kind of like if you're not using them, you're losing them. So IVF doesn't make people go through menopause earlier. It doesn't use up your antral follicles. It doesn't like hurt you in any way. It doesn't use up your eggs faster than if you didn't do IVF. I mean, similarly, like if you're taking birth control pills, like you're not saving up all your eggs over the years. That's the other question that sometimes people ask. So those eggs are dying all the time, whether you use them or not. So PCOS or no PCOS, low ovarian reserve, no low ovarian reserve, whatever, like the treatments don't affect sort of how many eggs you have left or the pace at which you use them or menopause or anything like that, okay? Somebody has a question about embryo grading. I think this is a really good question because I get a lot of patients asking questions about what we do or don't know from our embryos, because I think sometimes we use terminology that is a little bit, okay. Our nurse is texting me, distracting me from the talk. If anyone knows our nurse, Amy Byrne, good job, Amy. She's one of our favorite staff members there at ORM. Anyways, okay, so embryo grading. We, for the most part, so all clinics, I shouldn't say all, yeah, I would say all clinics have some sort of embryo grading that they use. There are different ways of embryo grading. Some clinics have their own embryo grading system. One of the most common embryo grading system is called the Gardner grading system, or the Gardner criteria. But those are all what we call morphologic embryo grading systems. And all that means is that the embryologists look at the embryos under the microscope and assess sort of how the embryo is developed, how many cells it has, and where it's at in its development, and often kind of how clear the cells are also. So, for example, when you're looking at a cleavage embryo, which is a day 3 embryo, some labs don't look at those embryos on day 3, but if they did, they would look at how many cells. Does it have 4 cells? Does it have 6 to 8 cells? How clear are the cells? Can you see them clearly? Do you see fragments in the embryo? When you get to a blastocyst stage, they start to look at, how well formed is the blastocyst? And blastocyst embryos, might be anywhere from day 5 to 7. So how clear are the cells in the embryo? Can you distinctly see what's called the trophectoderm, which becomes the placenta versus the inner cell mass, which becomes the fetus. And how are those cells made, and how developed is it? And so we know from studies that embryos that follow a very predictable, clear course have higher rates of implantation. So it's like, take it back to the race analogy, like the ones that make it to the finish line when they're supposed to may have a better chance of implantation. How clear they are, their development, that sort of thing. And so when we look at blastocysts on day 5 or day 6, or look at cleavage embryos, whether they're 4 cells or 8 cells, or whether they're morullas on day 5, whatever it is, that only has to do with implantation potential. It doesn't tell us anything about the health of the baby or the pregnancy or what the chromosomes are. Because sometimes, in a conversation about, we'll talk about embryo testing, like we'll talk about pre-implantation genetic testing. And a patient might decide not to do it. And they'll say, but you can still look at the embryo and see if it's healthy, right? And the answer is no, we really can't. We can look at the embryo and try to predict which is the embryo that is most likely to implant, or we can look at the embryos and speculate the implantation potential, or we can look at embryos after maybe a patient didn't get pregnant and say, yeah, well, these embryos weren't growing well, their embryo quality wasn't good. But it doesn't tell us anything about, I mean, I've had patients who have picked their best looking embryo and then have gone on to have a miscarriage of a genetically abnormal pregnancy. So the only kind of grading and there's actually kind of other types of grading too. There's like videos and that kind of thing that some clinics use, but in general, embryo grading is what we call morphologic, and it's just the embryologist reporting what that embryo looks like underneath the microscope and how it applies to what we expect an embryo to be at any particular stage. It's a little bit of a beauty contest with embryos, actually, but okay. Somebody is asking a question about fibroids, and I think that's an important question because a lot of our patients have fibroids. So it looks like this participant has asked a question about abdominal myomectomy. And abdominal myomectomy is a way to remove a fibroid or fibroids where the patient has an incision in her skin and the doctors use their instruments and hands to remove the fibroids, as opposed to doing like a laparoscopic myomectomy or a robotic myomectomy. And abdominal myomectomies do have a significant risk for abdominal scarring afterwards. Even when we're as careful as we can be, even when everything goes perfectly, there still is a significant risk for scarring afterwards. And I think it's important to recognize that. So, sometimes what I'll do, if I do an abdominal myomectomy and I really am concerned, I usually will try to have somebody have a fallopian tube test, like an HSG, in the months that they're recovering. So just to make sure that their fallopian tubes have not gotten scarred or blocked since, after the surgery in the healing time. I think in general though, if you've had an abdominal myomectomy and again, depending on your age, 6 months or so has gone by, well, you should, depending on when they told you could start trying. Some surgeons will recommend that patients not try to conceive for 4 to 6 months after an abdominal myomectomy to let the uterus heal. But if after that time and then trying, if you're not getting pregnant, especially depending on how old you are, it may be reasonable to either go to your OBGYN or your fertility specialist and say, hey, like, is there anything we can look at? Like, had we ever looked at the sperm? Let's make sure the sperm are okay. Should we look at the fallopian tubes again? Should we make sure there's no scarring inside the uterus depending on how the myomectomy was performed? Okay, we probably got time for one more since we started late. Let me just see if there's any other. Let's see here. Gosh, you guys, there's so many nice patients that are here. Some that I haven't seen in years. Hello, I hope you're all doing well. Okay. There's a question about there's a question a patient has about, she conceived and she her child has some health issues and they're wondering about whether she could advocate for her insurance company to help cover costs of things. So here's the long and short of it. There are some conditions that we know that people could carry that if they had children, the children could be quite sick. This might be things like hereditary diseases like sickle cell or cystic fibrosis or balance translocation. And those are things that we can look for by doing IVF and doing pre-implantation genetic testing. So that one's called PGTM, usually is what we're looking for, or other forms of pre-implantation genetic testing. So one of the things we need to do that though, we need to make sure that there is a specific gene or condition that we're looking for. So for example, if a couple comes and says, well, my child has autism, can you test for autism? We can't do something like that, but if you come and say, oh, my child has Fragile X syndrome, can we look for that? The answer is often yes. The issue is that sometimes insurance companies will not cover that. So, it may be that will be a little bit of a fight to have with the insurance company, or maybe not a fight, but just a suggestion that they could cover things. But to me, it makes perfect sense that they would want to help a family have a healthy child, because the insurance company would have to also pay for the child if they were sick, but that's another story. So I always think it's worthwhile talking to the insurance company, seeing if they can, if you can advocate for them, see if your doctor can help advocate for you. It's amazing, it can't hurt to ask. You never know what you could get. So I think it's always worthwhile trying to see if you can get coverage for those types of things. So, okay, one last question, I promise, and then I'll stop. Somebody is asking a question about Ozempic for PCOS. I have to tell you, I have not seen much on Ozempic for people with PCOS, and if that is better, or, in terms of weight loss, it may be very helpful, which would then affect insulin levels, which may help PCOS kind of indirectly. But I have not seen a lot of studies on it in PCOS and infertility treatment. So that will be something we'll have to look into. All right, everybody, I hope you're all doing okay. I know this is a very, very uncertain time right now, and we're all just going to have to get a little comfortable with the uncertainty of the situation right now. But I will tell you that, I would say your doctors in Ohio, because I've heard from most of the doctors who are in Ohio, even the ones I'm not at our practice, and everybody's working really hard, and everybody really cares, and everybody just wants to take care of patients the way they have, and to make sure that you all have options. So we're all working really hard. It would be great to have your help as well, if you are all comfortable making sure that your friends, your families, your employers, your congresspeople, whatever, the state stuff, that's the state people we need to talk to at this point, understand that we need to make sure that infertility treatment is allowed in Ohio. So hang in there. If you have more questions, you can always call us. If you have specific questions, if you're in our practice, or even if you're in a different practice and you have specific questions about your specific situation with your embryos or whatever, you can always reach out as well. But we are doing all that we can right now. So anyways, you guys, I didn't think I would be talking about all this tonight at this meeting. So maybe it was good that this was planned when it was, so we could talk. And I'm always happy to do one of these again in the near future if you find this useful. But for now, go outside, get some fresh air, walk your dogs, get some ice cream, whatever it is you need to do to feel good. Wake up tomorrow, go for a good walk, and keep working, okay? All right, you guys, talk to you soon. Bye.